Knee osteoarthritis is a progressive, inflammatory pathology driven by cartilage degradation. For decades, non-operative treatments offered temporary symptom relief, failing to modify the disease itself. Enter platelet-rich plasma. As an autologous orthobiologic, PRP targets angiogenesis and active inflammation directly, deploying key mediators like interleukin-1 receptor antagonist to alter the joint environment. Yet the clinical data is notoriously erratic. Despite a robust biological rationale, legacy trials of PRP for knee osteoarthritis yield wildly mixed efficacy. The variance is a direct result of relying on unquantified commercial kits and inconsistent injection techniques. The exact cellular composition and delivery of the treatment fluctuates from clinic to clinic. To resolve this heterogeneity, the American Academy of Physical Medicine and Rehabilitation convened a technical expert panel, publishing a comprehensive evidence synthesis. We are going to extract the core findings from that AAP-MMR guidance to construct a standardized, high-efficacy clinical algorithm for PRP intervention. The data shows that therapeutic success is an engineered outcome. It depends entirely on controlling exact variables throughout the clinical process. The first node of this algorithm begins before the patient ever enters the procedure room: patient selection. The optimal target demographic for maximizing effect size are individuals presenting with mild to moderate osteoarthritis, specifically Kellgren-Lawrence grades 2 through 4. Earning a SORT grade A recommendation, the panel specifies that these patients must exhibit persistent symptoms after already completing standard conservative care pathways. Focusing on systemic pharmacology, this flowchart maps the critical washout timeline. Routine medications like NSAIDs suppress cellular mechanisms, decreasing release of crucial growth factors. Therefore, patients must refrain from these medications for 1 week prior to the blood draw and 1 week post-procedure. Systemic optimization extends to patient habits. Performing high-intensity exercise immediately before the blood draw measurably increases both platelet yield and TGF-beta concentrations. Conversely, active smoking and recent alcohol consumption directly inhibit platelet aggregation and alter plasma fibrinogen levels. Failing to optimize the systemic environment sabotages the biological potential of the treatment before a single drop of blood is drawn. Next, we move to the formulation and processing phase. The centrifuge mechanics isolate the specific cellular layers needed for the injectate. Here, total platelet dose is the singular critical determinant driving the magnitude and duration of a positive clinical response. Legacy protocols often utilize doses under 5 billion platelets. Those low concentrations are directly responsible for the statistically inconsistent clinical results found in early literature. The formal recommendation states that both leukocyte-rich and leukocyte-poor formulations are equally viable for treating knee OA. However, there is one cellular component that must be strictly excluded from the final formulation: erythrocytes, or red blood cells. Including red blood cells introduces a severe biological hazard. When they break down in the joint space, hemolysis releases free heme into the synovial fluid. Free heme induces rapid chondrocyte apoptosis and triggers localized synovitis, initiating a destructive cascade that mirrors the pathogenesis of hemophilic arthropathy. Clinical efficacy ignores commercial kit brand names. It relies completely on mathematically hitting the 10 billion platelet threshold while rigorously excluding cytotoxic red blood cells. The final phase of the algorithm dictates the physical delivery architecture of the optimized formulation. Blind, landmark-guided injections suffer from an unacceptable failure rate, plagued by highly variable structural accuracy depending on the practitioner. This side-by-side comparison illustrates anatomical risk. To guarantee precise intra-articular delivery and prevent needle termination in the prefemoral fat pad, ultrasound image guidance is mandatory. Ultrasound serves a secondary necessity. It allows physicians to identify and completely aspirate existing joint effusions prior to injection, preventing the dilution of a highly calibrated PRP formulation. Inside the joint, there is a strict biological warning against intra-articular local anesthetics. This clip demonstrates fluid disruption caused when anesthetics meet a cellular matrix. These anesthetics possess a profound established chondrotoxicity. They actively destroy tenocytes, chondrocytes, and the newly injected platelets you just engineered. If an anesthetic is absolutely mandatory for patient tolerance, ropivacaine must be selected, as data shows it is the least detrimental to the orthobiologic environment. The delivery algorithm must adapt for an outlier demographic, patients with severe osteoarthritis featuring subchondral bone marrow edema. Standard intra-articular PRP fails in these severe cases because the primary pathology resides deep within the subchondral bone structure, inaccessible to superficial fluid. The AAPM-MNR issues a sort grade A recommendation, combining intra-articular delivery with subchondral intraosseous injections. By deploying a secondary intraosseous vector, the injectate bypasses superficial barriers to directly target and modulate dysregulated subchondral bone remodeling pathways. A perfectly formulated 10 billion platelet dose is biologically useless if delivered blindly into a fat pad, or chemically destroyed by standard local anesthetics. This complete flowchart represents the finalized, evidence-backed clinical algorithm built from the AAPM-MNR guidelines. Pillar 1 relies on strict patient selection, optimizing the systemic environment through a mandatory 1-week NSAID and antiplatelet washout. Pillar 2 mandates achieving a 10 billion total platelet dose while minimizing red blood cell inclusion, validating both leukocyte-rich and leukocyte-poor formulations. Pillar 3 guarantees accurate delivery via ultrasound guidance, strictly avoiding the cytotoxicity of local anesthetics. Adopting this algorithm demands a shift in modern clinical practice, requiring practitioners to abandon opaque, one-size-fits-all commercial kits in favor of mathematically quantified orthobiologics. It also requires defining exact clinical boundaries. PRP provides robust disease-modifying symptom relief and functional improvement, but the data does not support it as a structural cartilage regenerator. By treating PRP variables as precise, controllable architectural components rather than clinical guesswork, physicians can definitively alter the painful trajectory of knee osteoarthritis.